Thank you so much for having me. My name is Brandon Ayres. I'm from the Cornea Service at Wills Eye Hospital. My private practice is called Ophthalmic Partners of Pennsylvania. And thank you so much for the invitation to speak with you guys today. It's an honor to be here with you guys. So my topic today is trying to work smarter, not harder. How can we use Veracity to help us in the office and in the operating room, especially when it comes to toric IOLs? These are my financial disclosures. I do work with a lot of companies in the cataract space, but I'll make sure nothing gets in the way of this. So here's the question. How can I use a digital surgical planner to assist with astigmatism correction? And can I get something that's going to work right out of the box? That's going to make me pretty excited. So this is where Veracity really fits the bill. It works for me. It'll work for any surgeon right out of the box, especially in the way it connects to patients and connects in the operating room. So how does Veracity help us with patient selection? Well, let's go a little bit into that. All right. We are trying to be very efficient in the patient workflow in the office. First, a patient has to find you, and then they need to call the office and make a visit. There's a lot going on with the flows of the patients. Technicians see the patients, the surgeon sees the patients, recommendations are being made. Surgery has to be planned. There has to be a handoff. And in that patient journey, somewhere it's helpful if the doctor can learn about the patient's desires, needs, and wants prior to even entering the room. And that's where I think Veracity really helps. So let's start by logging into Veracity and seeing where it can be helpful in just getting to know the patients. So you're going to have a list of patients for the day, and I can pick the patient before I go into the room. And we want to know that patient, know something about that patient before we even get there. And that's where the questionnaire in Veracity helps us quite a bit. It's going to help us determine our patient's expectations. It's going to tell us a little bit about the lifestyle preferences of that patient, and even some personality traits. And this is really, really easy to do in the office, and it's all digital with no paper and captured inside Veracity. So the first thing we're going to have to do is send the patient a survey to take. And that can be done in a couple different ways. The easiest way is to just open up the patient's chart, ask for their cell phone if it's not already captured in Veracity, and send them a text message, and in that text will be a questionnaire. Now, the patient will have to fill out their date of birth and some demographics to make sure that they're not filling out somebody else's survey, but that's all taken care of through Veracity. Then the questionnaire is going to walk through several different questions, and they're very simple questions to ask and simple questions to answer. They're going to be things like, do you want to be less dependent on your glasses? And what patient doesn't want to be, more independent from glasses? Do you mind wearing reading glasses? Somebody who says no may be a good candidate for a monofocal or a toric IOL. Somebody who says I don't want to wear reading glasses may need something like a multifocal. Are they willing to accept some glare and halos to achieve better spectacle independence? Is there a history of monovision? Has that patient already tried using one eye for distance and one eye for near? And would you like to do that with cataract surgery as well? Have you ever had LASIK surgery? Now be careful on this one, because I can't tell you how many times I've seen somebody click yes on that, but they've never actually had LASIK surgery. Are you willing to pay some out of pocket for your surgery? Would you prefer distance vision or near? What's your priority there? And are you willing to wear glasses for some component of your day? And then, of course, there's a disclaimer that says, at the end, we can't guarantee anything, but thank you for the questionnaire. Now, I will have that information even before I walk into the room, and that's going to help me know what to do. And if that patient hasn't already filled it out or isn't very good at responding to text messages, we can send them or show them a questionnaire. I've even done it myself. I've taken a picture of the questionnaire for the patient, and that will bring the QR code then brings the questionnaire up directly on their phone, and they answer the same series of questions. So hopefully we have the information in the room already, but if not, we can still get it. And that already allows me to know how to steer the conversation as to what that patient's going to need and whether they'll need a premium lens, if they'll need a toric IOL, or if they're a monofocal or maybe a monovision candidate. So again, this is all done through Veracity, so having that digital planner makes an awful lot of sense. And that goes right into patient education. The Veracity Surgery Planner is portable, and it brings the data to me. And that's very different from prior generations of data collection, or the old style of data collection where I had to go get all kinds of papers in the office. This IOL master doesn't have the right IOL. Shoot. Let me see if Tammy can rerun these for me. Hey Tammy, you out there?
I heard you were looking for me.
Perfect. Wait a minute, I needed a different target for this biometry. This patient wants monovision. I'm gonna have to rerun this. Hey Tam, can you rerun the biometry for me?
I heard you were looking for me.
You know, with Veracity, that data comes right to me to the tablet. And I'll use this right in front of the patient. You can see here we're doing calculations for a patient, and it shows that they're going to be left with about a diopter of astigmatism. That comes right to me, and I'll actually show that to a patient. I'll show them my tablet. And then we'll just simply go back, choose a toric IOL, and we'll see that that level of astigmatism drops. And patients understand that. Look, your prescription is closer to 0. You're much less likely to need glasses. And then I can discuss that with the patient right there in the operating room. And before that exam is done, we've already made our selection for IOL for the day. Now, another key component of Veracity is that it is the data link from office to the operating room. So no longer are those two separate entities. What we do in the office directly translates to what we do in the operating room, and Veracity is the link between the two. And it'll help with patient's safety, patient IOL calculations, and even visualization in the scope of that surgery or of that patient's case. So let's go into the operating room and see how Veracity helps us while we are physically in the OR. Now for me, Veracity is one of the first things, or maybe is the first thing that I open when I get into the operating room. It helps me see what patients I have, and it's got notes on there as far as what patients need. So now here's a clinical scenario that I'd love you guys to see, and this does happen to me almost on a monthly basis. We're heading back. We're going to be taking that cataract out of your right eye. You ready to go?
You got it. I'm ready to go.
All right, let's get going.
All right. Oh, and hey, Dr. Ayres,
yeah.
I do want that toric IOL.
Oh. Now, back prior to using Veracity, this would have been a major problem, and I'll describe that here in the video. So a scenario like this used to be a disaster. I'd have to call the office, tell them to change the IOL or send the IOL master back or whatever it would be. But now with Veracity, I can just simply look up the patient's chart, unapprove the current plan, pick my new toric IOL, click approve, and by the time I get back to the operating room, that new plan's already going to be ready to go, and I can get the lens and get the surgery done. All right, so the changes are already all made here in Veracity on my tablet, so let me put this down. But now we want to go over to our microscope and make sure that it connects with Callisto. So the patient's already been uploaded. I uploaded all the cases first thing in the morning, but we're going to want to go and delete that patient's chart and then re-import it. So this is going to bring the new information over to Callisto so that we have all the proper markings that we need for the toric IOL. So here's our new data. We'll bring that patient in. And now the new toric IOL will show up on our screen. So now with Veracity, it's relatively easy for us to get this problem solved. It really shows the synergy and the integration between the office and the operating room and how simple that data flow is. You notice there was no USB sticks or the need to reload things. It's just right there on the microscope. So Veracity is used in so many different ways right there in the operating room. We even use it for doing our surgical timeout. And here's that video you're watching, seeing the scrub nurse and the tech look, seeing that there's the proper patient, they're doing the timeout, showing that the correct IOL is there. And it's even going to help during the surgery with direct visualization of that patient and carrying out the surgical plan. Now, when it comes to a toric IOL, Veracity is also the link. It's the link between the office and the microscope to help ensure proper toric alignment. Now, proper toric alignment used to be done all manually using a series of fancy markers, and I'll show you some of those, but it was basically a manual thing, and you can be off. And every degree of rotation decreases the power of the toric IOL by 3.3%. So 20 degrees off, and you've lost almost 2/3 of your toric power. So accuracy really is important. There's some pretty cool devices that help with this, but manual marking just isn't as good as a digital marker where we have imaging in the office that then directly transfers to the operating room. And here's just another manual mark that I placed, and now we are using a reference mark to then measure the steep axis. Again, just using some general, I think this is the 180-degree axis, and then we'll go off of there. Now, the IOL Master does take a picture of the eye, and it registers that picture in Veracity, and it registers the steep axis off of the image. So now there is more than one way that that data can be used. Some of the new lasers will actually use IOL Master data to register the steep axis using image guidance to show the steep axis or make marks on the steep axis during femtosecond laser cataract surgery. This is just one of those cases where we're using the Ally laser, but the patient's already been read or scanned on the IOL Master, and that data went directly to the Ally. Now, after the docking procedure is complete, we'll actually be able to show, it will know the steep axis based on the keratometry of the IOL Master, and it makes little tick marks on the capsule. We call this IntelliAxis C, which can be really, really helpful when it comes to aligning the toric IOL. So it's not just for Callisto or for visualization under the microscope. It also can interface with other instruments. Now, here is using the Callisto system. So this is a patient who had their biometry done in the office, and now we're in the operating room doing cataract surgery. And this patient is going to be having placed a toric IOL. So the magic here isn't the cataract surgery. That's pretty straightforward. We've already made our capsular exits. We're removing the nuclear portion of the lens in here. We're removing just the last little bits of cortical material. You will notice that I do have a couple of reference marks on the cornea, but they're not really needed for this patient because we've registered the patient with the microscope. So we've registered the picture from the IOL Master, and it's been referenced under the scope, and now that the implant is placed, the Callisto system will find the steep axis for me by using the registration image. So this is all transferred through Veracity. Here's another more complicated case where a patient had a phakic lens placed many years ago and has now developed a cataract. So in this case, we're not only going to be removing the phakic lens, but also removing the cataract, and this patient will also have a toric IOL. So the first step here is removing the phakic IOL, and this is not always an easy procedure. So we're using some micro instruments and a couple of tying forceps to slowly remove that very, very gummy sulcus fixated phakic lens. Now that the phakic lens is out, we can move on and we can take the cataract out using our traditional techniques, and the last little bit of cortex coming out. Again, you'll see my reference marks because I still put reference marks on the patients, but you probably don't need to because this patient was also imaged with our IOL Master and the planning done in Veracity. So here we see the reference image is found. It's showing us our steep axis without needing to use the reference image. And our IOL can be placed on axis, all directly visualized through the microscope. Really amazing technology. So in summary, the Veracity Surgery Planner is critical in all phases of patient evaluation, education, and even surgical planning and doing the surgery. We use it in the office to help evaluate patients' needs and wants, and that helps steer patients towards premium IOLs. Premium and toric IOLs. We actually use it as part of our patient education, showing patients that if they have a certain implant placed, it may reduce their dependence on glasses based on IOL formulas and showing them their residual refractive error. We then use that in the operating room, not only to do relatively emergent changes in IOLs, but also to directly visualize what's going on during that surgery to make sure that we're placing our toric IOLs on axis so that patients get the best results that they possibly can. And all this is done because we have Veracity and because we have the technology offered to us from Zeiss. Thank you very much for your time. I hope you've enjoyed this presentation.
Excited to be here. Today I'm going to be talking about the power in Veracity and why I think Veracity is really great and really helpful. Okay, so Veracity, one of the reasons why I like Veracity is because it comes back to astigmatism. And why do we care about astigmatism? Well, we care about astigmatism because in cataract surgery, I strongly believe the most important outcome is the patient's perception of the outcome. And we all like happy patients. And we have shown in many studies we've done, and we know this just through our own personal experience and the experience of our patients, that the happiest patients tend to be ones that are emmetropic. And kind of every step we get away from that, patients get less and less satisfied and eventually will end up being just frankly unhappy. Now, astigmatism really matters in this because even if they have an emmetropic spherical equivalent, small amounts of residual cylinder can really adversely affect the patient's perception of their outcome and their visual quality and acuity. And this happens at a much lower amount of residual astigmatism than I think we realized, or at least I had previously realized. And this comes from a study that our ops group did, looking at the effect of residual astigmatism on uncorrected acuity and patient satisfaction in patients that had undergone cataract surgery. This was done using a really large database of patients that are treated at multiple fiber refractive surgery clinics in the United Kingdom. The treatment algorithm was this: patients that had less than 3/4 of a diopter of astigmatism didn't have any treatment for their astigmatism or had unaccessed incisions, which is what I do in my practice, what I have done in my practice. Those between 3/4 of diopter and less than 1.5 diopter all got limbal relaxing incisions. In this study, there were femto limbal relaxing incisions. I don't have a femto laser, so I usually do them with manual. Those with 1.5 diopter or greater of astigmatism had a toric lens placed. We looked at outcomes 3 months after surgery, including outcomes from a patient-reported outcomes questionnaire based on the Prowl questionnaire. So this was a big study. It was almost 35,000 eyes, almost 19,000 patients, and about 2/3 of them completed that post-op month 3 questionnaire to look at patient-reported outcomes measures. The majority of patients got multifocal non-toric lenses, with a minority getting multifocal toric lenses, and then some patients elected for monofocal non-toric or monofocal toric lenses. Let's look at the outcomes. So post-operatively, the astigmatism had a really large impact on uncorrected distance visual acuity in the multifocal IOL group. This is looking at the percentage of patients in blue that are 20/20 or better, or the percentage of patients in orange that are 20/16 or better. And the amount of astigmatism that has an impact on the acuity is really astounding. For every 1/4 diopter increment in residual astigmatism, starting from 0 to just 1/4 diopter, we see a drop-off of about between 6 and 10% of patients achieving that level of acuity at the 2020 level, and it mirrors that at the 2016 level. So residual astigmatism, even at the 1/4 diopter amount, has an impact on acuity. This is in multifocal patients. We looked at a logistic regression analysis controlling for many other factors, including patient age and gender, and all the other factors that can potentially affect residual acuity. We saw this effect persist. So postoperative cylinder going from 0 to like even a 1/4 diopter to a 1/2 diopter residual cylinder, you were 1.7 times less likely to get to 20/20. And the magnitude of that increases exponentially with every increasing increment of cylinder. Postoperative hyperopia, postoperative myopia also have a big impact on getting to 20/20 or not, but astigmatism, even at that 1/4 to 1/2 diopter level, has a pretty substantial impact. Now, when we look at monofocal lenses, we think that monofocal lens is probably more tolerant to like astigmatism. Maybe we're a little bit less likely to correct for that. Actually, the pattern is exactly the same. We see the exact same thing, that even going from 0 to a 1/4 diopter of residual astigmatism and from a 1/4 to a 1/2 diopter residual astigmatism, we see those acuities dropping off. Again, 20/20 or better in blue, 20/16 or better in orange here. So even in monofocal lenses, astigmatism really matters in how well patients are seeing. This was surprising to me because honestly, I thought we would start seeing an effect starting at about like 3/4 of a diopter of cylinder. But the fact that it was really dramatic, even going from 0 to a 1/4, I was surprised by that. It has changed my practice. Again, almost identical results when we look at the logistic regression model of not achieving 20/20 uncorrected distance visual acuity. Huge impact with going even from 0 to a 1/4 diopter of residual cylinder. Similar results, almost identical actually, for postoperative hyperopia and postoperative myopia. I think we have a narrative in our heads that monofocal IOLs are more tolerant to residual refractive error, or maybe the patients that are electing those are more tolerant to residual refractive error in terms of acuity. I think that narrative is probably false, and I think we need to be looking really hard at astigmatism. This is the part that really, I think, drives it home for me. This is looking at patient-reported satisfaction at 3 months after surgery and residual astigmatism in monofocal lenses. When we look at this, we can see, and in here the light gray is very satisfied, The dark gray is satisfied, and then the darker gray and black are neither satisfied or dissatisfied or very dissatisfied. When we look at this increasing amount of residual cylinder, we actually see a decrease in the amount of patients that report they are very satisfied and satisfied. So that is having that visual acuity that they're noticing is having an impact on their quality of life and how they feel their vision is. Now, when we look at the odds ratios of not being satisfied, we actually don't see a statistically significant effect at the quarter diopter range. So even though patients have a quarter diopter of residual cylinder, they're less likely to be 20/20 at that range. They don't perhaps notice it as much. And this may be due to sample size. It may be due to the fact that, patients are a little bit tolerant of that level of refractive error. But really, once we start getting into the 3/4 of a diopter range, patients become notably less happy with their visual acuity. We see the same exact trend in a multifocal, and this is maybe why we think multifocals are more sensitive to residual cylinder, because the effect is pronounced in a multifocal. We are near significance at even that quarter diopter range, but really once we get into the 3/4, half the 3/4 diopter range, we really start seeing a significant drop off in patient-reported satisfaction. So astigmatism matters. Even low levels of astigmatism really matter in patients with both monofocal and multifocal IOLs in terms of visual acuity, but also, and more importantly, in terms of patient reported happiness with their vision. So this brings us to Veracity and why I like Veracity. Veracity is a web-based platform for surgical planning. You can load into it all the lenses that you possibly use. You can load into it. It automatically will interface with your biometers, with your topographers, and the electronic medical record and pull this data in. And it offers a really, really easy platform to go through to select lenses, to change targets. Right here, I just changed to a -0.5. This patient was opting for monofocal monovision with toric IOLs in both eyes. And, easy to kind of customize what you want for the patient without going back to recalculating, putting your formulas into an online calculator, kind of collecting that data. The single most common reason for lawsuits in cataract surgery really is wrong IOL errors, and Veracity, and the biggest reason for that is transcription errors. Really, Veracity absolutely eliminates the need for transcription at all, which I personally love as somebody who is dedicated to cataract surgical outcomes. But I also love it because I can say, well, this patient actually has prior refractive surgery. They've had hyperopic LASIK. I'm going to put that in, and it pulls up the right calculators. Oh, they have keratoconus. I'm going to put that in, pulls up the right calculators. I'm going to target a little bit of mini monovision for this patient. I'm going to target the distance in their dominant eye and a -3/4 in their non-dominant eye, and automatically recalculates to that. Oh, I'm going to start using a new IOL. Let me import that, and then suddenly, I'm going to make that my IOL choice, and everything is automatically calculated for that. I also love it because it sends everything to the surgery center, implant coordinators without any hassle, so they can just go through and order those lenses. It's a really great platform for A, like preventing errors, and then B, enabling the best possible, position experience really for calculations. My OR nurses also love it because it's easy for them to verify the implant to make sure that the correct implant is in the room. They don't need to be shuffling through sheets of paper. They can just look at the plan for that patient, look at the box of the IOL and say, okay, this is the IOL that is for this patient. Now, because I'm a little bit of data geek, the other reason I love Veracity is that it's a web-based platform and people all over the country are using it. It's only available in the United States right now, but people everywhere are using this. And because Veracity is a web-based platform that databases things, you can have a huge amount of data that comes into it. Looked at the data actually almost a year ago now. At that point, there were 264,000 cataract surgeries in that database that had 1 month refractive outcome data input by 476 different surgeons, which is a lot of data, which is cool. And allows us to give us like a peek at kind of like the state of cataract surgery in the United States in a way that we've really never been able to do before. And I should just say that, because it's web-based, you can export the data in a de-identified fashion. So, completely preserves, provider, patient, HIPAA protections. But you can look at this data and see what people are really doing. And, first of all, like, hey, what formulas are people using? We've got a lot of data now what formulas are good. And turns out, actually, most people are using the Barrett Universal 2. But there are still some people that are using the Holiday 1, the Holiday 2. Some people are using the Kane, Barrett TrueK, SRKT, and the Zeiss AI calculator. So there are 1.5% of our surgeries out there are being planned with the Holiday 1 because some people really, really love the Holiday 1. That also kind of blows my mind. Another easy question to ask is like, hey, what type of lenses are people using? What is the range of lenses? And it turns out most common, 71.67% of patients that are getting cataract surgery in the United States right now, more or less, are getting a monofocal IOL. 12% are getting a toric IOL. And the remainder are getting some combination of an EDOF multifocal light adjustable lens. So still a heavy prevalence for monofocal IOLs, at least in the United States. That's kind of the generic stuff. What other questions can we ask that are interesting? Like, how are we treating astigmatism? Like, we know that astigmatism really matters. How are people approaching it? And specifically, like, what are we doing now that we know that low astigmatism actually really matters? What are we doing with low astigmatism? So, when we looked at this data set, there are 40,289 eyes that had between 3/4 and 1.5 diopter of corneal cylinder on keratometry. And because I think in practice patterns in the United States, we didn't look at lower amounts of cylinder to see if anybody was giving LRIs for that. We looked at this kind of intermediate range between where we know that there's a toric IOL available and where a lot of people would just leave untreated. And so of these, a little over half were uncorrected. About 10,000 got toric IOLs and about 5,800 got LRIs or astigmatic keratotomies. And of this, in the three groups, the mean preoperative cylinder was a little bit higher if you got a toric IOL, pretty similar if you got an LRI AK or were uncorrected. And things get interesting when we start looking at axis of cylinder. So when we look at eyes that got a toric IOL, they were way more likely to have against the rule cylinder. Eyes that got an LRI or AK were way more likely to have with the rule cylinder, and it was pretty even balance for uncorrected. Now, this is where things get very, very interesting. How much if our goal is to get people to 0 residual cylinder, how much residual cylinder you have after being corrected is dependent upon your access and the amount. We look at patients between 3/4 and 1 diopter of preoperative corneal astigmatism. If they had with the rule cylinder, they did pretty well with both a toric and an LRI AK. But when we go to against the rule cylinder, they did way better with a toric and way, way better than if they were uncorrected. So with the rule, AK, LRI, and actually even uncorrected, performing pretty similarly against the rule. Big impact of having a toric IOL. If we look at those with a little bit more, we step up in a quarter diopter increment to those with between 1 and 1.25. We can see that effect starting to become a little bit more magnified. In the with the rule group, we can actually now see a little bit of differentiation between a toric and an LRI AK. And in the against the rule and oblique group, we can see a pretty substantial now differentiation between a toric, LRI AK, or no treatment. And again, when we go up in cylinder to 1.25 to 1.5 diopter, that effect really becomes magnified. So in the with the rule group, there's now a pretty great, we're at 3.35 diopters on average residual cyl in a toric IOL, and almost 0.6 in an LRI AK. In the with the rule and the against rule group, that is substantially magnified, and there's no treatment. There's really minimal effect. We look at the odds ratio of achieving less than half diopter of cylinder, which is kind of that visually or patient-reported outcomes significant group. We can see that depending upon the amount of preoperative cylinder and the way your axis is distributed, there are some groups that do much, much better with a toric IOL. Toric IOLs do better in general for everything, but really, really impactful in the higher amounts of cylinder group and then also the width rule group. So toric IOLs outperforming LRI AK pretty much in all of our groups. So the other great thing about Veracity, and so anyway, so backing up, toric IOLs, think about them in lower amounts of astigmatism. LRIs, AKs, think about them in kind of the sub 3/4 threshold. The other great thing about Veracity is that it really enables continuous optimization because data is coming in, outcomes are coming in, and it allows the A constants, the constants that we use for IOL calculations, to be continually optimized. And this is just looking at like a study we did looking at optimizing the A constant using the data from Veracity, really actually driving the mean predictive error down with that, even below what has been published before by Kane et al. So the more data that comes into Veracity, the better your outcomes become because of the A constant optimization, and the better everybody else's outcomes become too, which is great for just patients in general. So in summary, astigmatism really matters. Even low amounts actually really matter. So we need to be thinking in that sub 1.5, sub 3/4 diopter threshold to really get the best patient outcomes. I love Veracity because I think it really simplifies the surgical workflow and it enables us to collect data on a large scale to improve our collective practices. So I'm getting better and you're getting better. We're all getting better and our patients are doing better together. Using Veracity, inputting those outcomes really helps improve future outcomes for everybody and helps give us happy patients. So thank you very, very much.